I think many of you are familiar with cancer being a big burden in our society, and the way we make innovations is through clinical trials. So today I'm going to share with you a clinical trial which actually has two, I think, innovations locked into it. So one of the things that we tend to do is we find things in the laboratory, we try to translate them into the clinic, and oftentimes when this is the framework we follow, about less than 1% of what we think might be important actually turns out to be important. And it turns out maybe the best model is not a mouse or a rabbit or some other animal, but might actually be the human. So how do we do this? So we designed a trial here at UIC called a window of opportunity study. We invite patients and with community input design this trial. And the fundamental question was, in this time when a woman gets diagnosed with cancer and is waiting around for all her appointments to happen, you oftentimes burn a month of time. Can we leverage that window and do an intervention for this patient that not only might help the patient, but teaches us about the disease itself? Most of the time what happens is the opposite. We do a massive trial, roll the dice, and hope we get a good answer. And that oftentimes doesn't apply to all the patients in the study. So we want to do something more intimate, more personalized. So what you're looking at here is the schema of such a trial. So the patient gets diagnosed, and here in this study we give a drug called 5-azacitidine. This drug has been around for 50 years. We give it in a very small dose, and there's a signal, a hint, that this drug might modify the immune environment of a cancer. And maybe we can force cancers that didn't care about the immune system, or the immune system didn't care about the cancer, and maybe force the cancer to care about it, but we have to prove that. And so we did this in actual humans with the real disease and asked this question. So you can see that study schema there. So this is just some of that data. Now the mechanism by this, the way this drug works is it turns on these ancient retroviruses that's in all our genomes. These are tightly controlled so that they don't just rampantly turn on. Well, this medicine, when you give them, actually turns them on. And what you're looking at here on the left is two such patients where we saw in one patient this actually worked and in another it didn't. And so the red bars show you the patient that started turning on these ancient retroviral genes. Now, if you make ancient retroviral genes turn on, you also make ancient retroviral proteins. We don't like those proteins. Our body's engineered to fight those off and defend against them. So we're now forcing cancers to make a protein that's really not good for them to make because it's going to make the immune system interested. So this is showing you a patient where we're looking at and marking specific types of killer immune cells. They're in the tissue. They're nowhere near the cancer cells. And then after we expose the cancer to the drug, you see all that white stuff? That's the immune cells finding the cancer cells. They're now kissing each other, whereas before they were far apart. And so we measured the distance, and you can see for some patients this distance in space from where the immune cell was sitting in the tumor to where the cancer was has been collapsed. And in other patients, there was no relationship. So we're also now heading towards a biomarker. So what I hope I've convinced you of is that maybe we can think about clinical trials differently. We can learn from our patients in front of us. And then as we learn, we're developing both the marker, but also potentially the effective therapy to then make these drugs work. And we're forcing cancers that were previously not even engaging the immune system to now be engaged by the immune system. Thank you.